final Excel in Your Future PT Career series for the year. This will final out the year. I think this is number 18 or so that we've done since we've started this back in 2024. So super excited. And we have a very awesome speaker to share some of her background with you today. This is Elise Tamburelli. Elise Tamburelli is a physical therapist, board certified orthopedic specialist, a certified spinal manual therapist, and a fellow of the American Academy of Orthopedic Manual Physical Therapists. And as a matter of fact, she was one of my mentors in my fellowship journey. That was about 3-4 years ago. So it's super exciting to have her here as well. Confluent Health, mind you, for students that are new here, Confluent Health is a musculoskeletal organization made up of physical therapy, occupational therapy, and speech language pathologists. And we specialize in outpatient private practice, outpatient physical therapy, outpatient occupational therapy, speech language pathology, but also industrial health and post-professional education with our evidence in motion partner. Elise is going to give us a wonderful conversation today surrounding cervicogenic headaches. And what I would encourage you to do, if any questions come up and arise, hit that Q&A function at the top bar here on the window that you see. And then after Elise finishes her presentation, we'll review some of the Q&A at the end and she can answer some of your questions. So looking forward to a wonderful hour with Elise, and let's have her take it away.
Thank you, Zach. Always good to be here. Good to hang out with you still. Zach pretty much did my whole intro for me. I'm Elise Tamburelli. I practice at Texas Physical Therapy Specialists, which is in our Confluent Partners brands. I just had my 15-year anniversary of graduating PT school, so I've been doing this quite a long time. And in the years that I've been doing it, you know, we've seen trends come and go. We've seen paradigms shift. But one thing that really holds true throughout all of physical therapy and throughout my entire career has been that experts do the basics well. So Zach mentioned that I was in fellowship. I did fellowship. I've been a fellowship mentor. And part of what I thought I was going to learn in fellowship was how to do all these like amazing manual therapy skills and like do all the stuff that nobody else could do. And that was partially true, but it didn't necessarily have to do with all the manual skills. What it taught me how to do better than most people was the basics, meaning a good subjective evaluation, differential diagnosis, my objective exam, and then pairing my treatment really with my patient's impairments. So that's a little bit about my background. Before I start sharing my screen with you guys, I just want to say thank y'all. I know that we are a week out from Christmas and the holidays are nuts. So the fact that you guys would log on and spend time with me here around this holiday season means a whole lot to me. So thank you guys. And just be proud of yourself that you're putting the work in to advance your career as well. So without further ado, let me go ahead and start sharing my screen. So like Zach said, we are talking about cervicogenic headaches today. I know it's a cheesy title, a real pain in the neck, but I do love it because even though we talk about cervicogenic headaches as headaches, they really fall into the category of neck treatment or treatment in our cervical spine. And even so much that sometimes people will come in and you'll ask them if they have a headache and they'll say, no, I don't really have a headache. I have head pain, right? And so it's this interesting little category of headaches that I think can be a little bit mystical and mystified by the general population. But actually it's relatively simple to treat from a physical therapy side of things. Not necessarily simple in terms of complexity, but simple in terms of it's not really complicated. We find the impairments, we treat the impairments in a really specific way. So hopefully by the end of our time together, you'll feel like you have a pretty decent handle on cervicogenic headaches, both diagnosis and treatment. And this is something that will really set your career off on the right foot forward because it's something that not everybody knows that we can do. So now you guys can shout it from the rafters that we can treat headaches and that we're really good at it. So quick little poll here. I know you guys can't see each other and I can't even really see you, but I want you guys to think about how many of you have ever had a headache? Chances are it's probably all of you, right? This is something that most of us, most of the population in America and the world has some type of headache, right? So I want you to think about when the last time you had a headache. Where did you feel it in your head? Was it in the front? Was it in the back? Did you have any other associated symptoms? Were you nauseated? Did you have a hard time with light? You had to wear the shades inside, Bono style, right? I want you to pay attention and to think back about how that headache presented, because really how those headaches present is one of our very first clues into what type of headache our patients are presenting with. And yes, there are many different types of headaches. So that's the first thing we're going to talk about here, is just how many different types there are. And this is by no means, you guys, an exhaustive list. This is a pretty drilled down, condensed list of headache types, just to start to delineate some different diagnostic buckets here. And I use the word buckets because that's how I think about diagnoses. So I think about diagnoses or hypotheses as being buckets. And then all of the data that we gather that either rules in a bucket or rules out a bucket are like marbles. And so as we hear things and as we see things and as we kind of start to predict things that lend themselves to a specific hypothesis, it's like putting marbles in that hypothesis bucket. So when we're talking about headaches, these are 4 buckets of headaches that are what we're not talking about today. But before we get into what we are talking about, it's very important to figure out what we are not talking about. And honestly, figuring out what we're not treating is most often our first line of defense with getting really specific with what we are treating. So let's talk about some of these other headache buckets. We have migraines. We have VOR, what we call like ocular type headaches. We have systemic headaches linked to maybe our cardiovascular system, our hormonal system, endocrine. And then we have this other kind of big bucket, amorphous bucket called central, right? And we'll talk about each one of these specifically. And even though, I talk about these as buckets, there's always going to be overlap, you guys, right? So just know that each of these don't completely exist in isolation, but how many marbles you have in each bucket would really help you figure out which route to go in terms of treatment. So what do we usually think about with migraines? A lot of times with migraines, our patients will say that they have a sensitivity to light and sound, right? If any of you have had a migraine, you're like, I just want to go lie down in a dark room, nobody talk to me, maybe put an ice pack on my neck because I think my head might explode and I also want to vomit everywhere, right? We have nausea, we have vomiting, we have light sensitivity, sound sensitivity. A lot of times it's the whole head or it feels like a vice grip on your head. This is a very unique type of migraine or a type of headache. A lot of times migraines are cyclical and a lot of times they have triggers. Sometimes a trigger can be a different type of headache, but sometimes a trigger can be smells. Sometimes people are really sensitive to change in barometric pressure, right? There's usually some type of trigger that chronic migraine sufferers typically know is their precursor to their migraine. Then we have these ocular type headaches. Ocular headaches are a lot of times associated with eye strain or like busy visual environments. If any of you have ever done a really long road trip where you're in an environment that you're not familiar with, you're on a freeway, maybe God forbid I-35 in Texas, and there are cars everywhere and you're really focused and your eyes are scanning all the time so that you don't get hit by anybody driving crazy in Texas, that can sometimes cause an ocular headache. It's kind of across the front, it's behind our eyes, it might be a little bit in the back of the head, but a lot of times that's where we feel it. It starts with this eye strain. It can sometimes also be associated with dizziness. This type of headache is often closely linked to the type of headache that we're talking about today, but alas, we are not really digging into this bucket today. Then we have this systemic bucket, this cardiovascular, hormonal, endocrine bucket. A lot of times this is obviously related to those types of things. So if it's a cardiovascular headache, sometimes it's related to the patient's blood pressure. They might feel a pulsating in their head. They might even have some visual changes or some spots in their vision. Those are all kind of emergent things, right? If it's hormonal, it can be related to the menstrual cycle. What part of our cycle do we usually get those headaches in? Sometimes if it's endocrine, it can be related to blood sugar. Think about like a hypoglycemic event or a hyperglycemic event when we're either really low or really high with our blood sugar. Sometimes that can trigger a headache. Sometimes if you're on the hyper side of that glycemia, you can even get some blurred vision. Or sometimes with the cardiovascular, you can get some double vision or, like I said, some spots. So a lot of times there will be some type of visual disturbance with this as well. And then our final bucket that we're not actually talking about is central headaches. And these are usually people that have a history of concussions or other type of traumatic brain injury, some type of head trauma. These are usually chronic and repetitive, and there was a really clear event or a mechanism of injury that caused this. So why is this important if this isn't what we're talking about today? Because that's the point. This isn't what we're talking about today. And when your patient comes in, when they say, I have a headache, these are the things that first and foremost, we need to decide that it's not, so that we can really start to focus in then on what it is so that we can be accurate with our treatment. So let's fast forward now to cervicogenic headaches. So these are the type of headaches we really like to treat in PT. Not saying that we can't do anything about those other types of headaches, but these are really our bread and butter when it comes to headaches. So here's our last bucket, our cervicogenic headaches. These present very uniquely, and they're very easy to identify in terms of pattern recognition, and we'll be talking about this on the next slide. But first, just a little bit of stats. So about 15 to 20% of chronic headaches can be labeled as cervicogenic headaches. I'm going to be really transparent here. Our stats on this, they ain't great, right? Like, because so many people have different types of headaches, and so many studies looking at headaches don't do a great job of differentiating what type of headache people have, that this is the best guess that we can make based on the data that we have. But I would venture to say it might be a little higher than that. But the best data that we have says about 15 to 20% of chronic headaches can be labeled as these cervicogenic type headaches. This is usually higher in a specific population, such as people that work at computers all day, people that have to sit in a certain posture with maybe a little bit of a head forward, maybe a little bit of hunched shoulders, and not a lot of movement. If we're talking about these headaches coming from the neck, that makes sense, right? So anything that puts your neck in a really specific position for a long period of time, those people can be predisposed to having these types of headaches just because of the neck positioning. This is also typically our younger patient population, about that 18 to 45-year-old age range. Not to get too into the weeds, but this has to do with really the viscosity of our discs and our neck, and how our necks and our spines and our discs respond to gravity and sustained positioning. So if somebody walks in my clinic and they're like, hey, I'm 35 years old and I get my headaches when I work at a computer for 6 hours, my spidey sense is already thinking, ooh, this might be a cervicogenic headache. This is fantastic. And then the next thing I have to look at is, what does this headache look like? So here we go. Here's this funny little thing that I stole from the internet, and it has a typo. So that's why I have to make sure that you guys know I didn't make it. So here's like our patient presentation, right? We have migraines, the cervicogenic stress type headaches, and then our physio student or our PT students, right? Or all of us right now around the holidays when it's just our entire head is about to explode because we have so much to do and not a lot of time to do it, right? So what we're really looking at right here is a cervicogenic headache. It usually starts right around the base of the head and comes up around the skull and will center behind an eye. You'll hear this a lot of times called a ram's horn distribution. And when I was in PT school, that's what we learned. It was, hey, this is a ram's horn headache, a ram's horn headache. And I thought that that meant that when a patient came in, they would be like, yeah, I have a ram's horn headache. Nobody has ever said that to me in 15 years. But what they will say is, my headache starts right here. It's really at the base of my head. It's really like head pain. And then it kind of radiates up and it centers behind an eye. Notice on this as well that it is usually unilateral. Most of our cervicogenic headaches happen on one side of the neck and the head, which is one of our really big differentiators between some of those other types of headaches. Because of the way our head and our neck interact together, we can also have these two presentations for cervicogenic headaches. This top one shows kind of the eye up into the head and back around. And then the second one is even some jaw pain or into the ear, right? So if somebody walks in with any of these presentations, and from our first page, they're already in that appropriate age range, and they've told me that their symptoms come on with a sustained neck position, I'm thinking, okay, this is probably a cervicogenic headache, but I still can't treat it yet because I still have to make sure that it isn't something else. This is something that we do as PTs all the time. Our pattern recognition kicks on and I'm like, oh, hey, this looks like a cervicogenic headache. I'm just going to treat it, right? But what happens when we do that is that we could potentially be missing things that are other diagnoses or contributing factors. We can also be setting ourselves up to miss red flags and potentially be unsafe. And our first rule of PT is to make sure that our patients are safe and appropriate to be seen in physical therapy. So even though it already sounds like a cervicogenic headache and looks like a cervicogenic headache, I still can't treat it yet as a cervicogenic headache until I do my due diligence and rule out all of the other red flag and scary things. Now, to make those scary things a little bit less scary for this particular lecture, I just want you to remember SNOOP DOGG, right? So we have this acronym, which is SNOOP. And this is a helpful tool to help us think about all of the things that we need to rule out when we're talking about cervicogenic headaches. So the first S is systemic symptoms. So one of the questions I'm going to ask my patient that comes in with this headache is, have you had any fevers, chills, sweats, any nausea or vomiting? And then have you had anything like extensive weight loss without trying? Right. So what I'm looking for is, could this headache be caused by something else going on in the body, whether it's an infection, whether it's some type of neoplastic syndrome or cancer, or whether it's some other system causing this headache? If somebody has a cervicogenic headache, they're not going to have an associated fever. They're not going to have chills, sweats. They're not going to have any just like generalized fatigue and malaise. They're going to answer no to all of those questions, which once again then takes a marble and puts it in my cervicogenic bucket. Then our N is neurologic signs and symptoms. Some of you might be familiar with this little trick that we have called the 5 Ds and 3 Ns. So the 5 Ds are diplopia, which is double vision, really specifically vertical double vision, dysarthria and dysphagia, which are trouble speaking and trouble swallowing. So when you get your headache, do you have trouble speaking? When you get your headache, do you have trouble forming words or finding words? Do you have any trouble swallowing when you have these headaches? And then we also have dizziness. So if your patient says, yeah, I have dizziness, and it's not like a normal dizziness that we would expect to come from the neck, it's like room spinning or lasts for 5, 10, 15 minutes. That's a type of dizziness that isn't a dizziness I want to go poke around with when it comes to headaches. And then our 5th D is drop attacks, meaning, hey, have your legs ever just given out at the same time and you've just gone down? And this isn't because of pain. It's just like a holy cow, signals aren't making it to your legs, right? So those are the 5 Ds. Once again, diplopia, dysarthria, dysphagia, dizziness, and drop attacks. The A stands for ataxia, which essentially means, hey, are you walking around like you're on a cruise ship that's in turbulent waters? Or is your gait changed? Do you have a wide base of support and you're kind of walking like you're off balance? Sometimes your patients won't notice this. Sometimes their family notices this, right? So sometimes you can say, hey, is your husband or wife, your kids, your caregiver notice that you're walking differently or walking funny? And that's our A for ataxia. Once again, that's a neurological sign that is not associated with the cervicogenic headache. So that would be kind of a red flag thing. And then we have our 3 Ns, which are nausea, which we've already talked about, nystagmus, which is this rapid beating in the eyes, and then numbness. So I'll ask my patient, do you have any numbness specifically in both of your hands or both of your feet at the same time? And if they say no to all of those, my 5 Ds and 3 Ns, then once again, I feel pretty good that I can put a marble in my cervicogenic bucket. Our first O is onset. So remember I told you guys that our onset of cervicogenic headaches is usually after sustained posturing of the neck and head. So if your patient says, yeah, I just am, I'm just walking around and suddenly I just like feel this really fast, like sharp pain, and then it goes away in under a minute, that is not a cervicogenic headache, right? Cervicogenic headaches usually take a pretty long time to build, and then they last for a while once you get them because it's all about that sustained posturing. So if I hear an onset like that, I'm automatically thinking, nope, probably not a cervicogenic headache. The next one is older, and this makes sense because we already talked about the age for cervicogenic headaches are usually under that age of 45. Now, does this mean it can't happen in people over the age of 50? Absolutely not. It's just that's something that makes me think, ooh, what else do I need to be looking at to try to figure out if this maybe isn't just a run-of-the-mill cervicogenic headache? And then the P is a, SNNOOP, right? So we have 4 Ps here. So the first one is a previous headache history, meaning, is this a headache like you've never had before? Is this a headache like, oh my gosh, this is the worst pain imaginable and it's in the front of my neck and it's in my head and I've never experienced a headache like this? If that is the case, probably not a cervicogenic headache, and that's a little bit more red flaggy. So that's something that's really going to put up a spidey sense for me. And then postural or positional. This one's tricky because we talked about the fact that cervicogenic headaches usually are postural and positional. So what this is actually referring to is, do you have a headache when you're sitting that goes away when you lie down? That's usually related to more of those blood pressure type changes. So specifically, if I'm already thinking that they might have a cardiovascular type headache because maybe they have ringing in their ear or they have a whooshing sound, or they have a pulsating headache, and then they lie down and it feels better, that's not the type of positional changes that I'm thinking of when I'm thinking of a cervicogenic headache. And then is it precipitated by a valsalva or exertion? Once again, that would be something like if there's strain or bearing down, or like I lifted weights and I pushed really heavy to make my PR and then I got a really pounding headache. That is not a cervicogenic headache, most likely. That is a different type of headache. So I want to ask if their headache that they got was preceded by any of those things. And then the very last P is papilledema. So that's just a swelling of the optic disc and the optic nerve. And that's really associated with something going on in the brain. Lots of different things that could be. That one's a little harder for us because we're not necessarily going to be looking at people's optic nerve, but that'll be associated with things like dizziness, nausea, double vision, all of that. So if you remember this list, these are the things that should not be present when we're treating cervicogenic headaches. So if these are the things that aren't present, what most likely will be present? We've already talked about our subjective, or what the patient will say and where they say their symptoms are. So now let's talk about what we're going to find in our objective exam. Our objective exam, meaning our tests and measures that we do with the patient so that we can try to find the thing or the things that are really contributing to their symptoms that then we can go back and directly or indirectly work on to treat their symptoms and their function. So there's a couple really key things that will usually show up in an objective exam with a cervicogenic headache. So one of these, remember, it doesn't have to be all four of these things that I'm going to talk about, but these are the things that will typically be present. So sometimes your patient will have a limited cervical active range of motion, specifically with unilateral rotation or side bending. So we're assuming that all of these objective findings are happening within our bigger objective exam, right? So if I'm coming into my objective exam, I need to make sure I'm doing my due diligence of ruling out other body regions that could potentially be mimicking or referring to this area. And then once I screen all of those and rule all of that out, then I get to get in here and actually find the things that are causing the cervicogenic headache. So we're assuming I've done flexion, extension, right? All of these other cervical ranges of motion. And then when my patient either rotates, or side bends, I'm probably going to see a limitation, and it should line up with the side that they have their headache on. We're going to put this all together in a case study at the very end, don't worry. So that's one of the first clues that we might have a little issue with the upper cervical spine that can be causing the cervicogenic headache. The next thing that we have is called a cervical flexion rotation test, or the CFRT. I'm going to talk about these next three tests on the next couple of slides, so I'm not going to go into them in depth here. We'll probably also find some unilateral hypomobility plus or minus pain with upper cervical segmental mobility testing. That is a lot of words to say when we actually get into the spinal segments to test how those segments are moving on each other in the upper part of the neck. On one side or the other, we're going to find some segments that are stiff and or potentially painful. The stiff versus painful, I don't really care, because at the beginning I just care yes or no, does it move, and yes or no, is it painful? And if I get something that doesn't move or is painful in this area, it is something that could potentially be related to headaches. So we're going to go through each of these. So the cervical flexion rotation test, this is essentially what it looks like, and it's designed to stress the AA joint, the atlantoaxial joint. This is also known as C1, C2. So when we're talking about cervicogenic headaches, because of referral patterns, which I'm going to show in a couple slides, we're really just talking about our third cervical vertebrae and up. So anything from the skull to C1, C2, and C3. Anything below C3 doesn't typically refer up into the head, so won't usually be implicated in a cervicogenic headache. So what's really cool about this AA joint is that it's shaped, the joint spins on the axis, essentially. So it has a ton of rotation. So the C1 and C2, it's our spinny joint, and it is actually responsible for about 50% of your neck's rotation. So if you just look over your shoulder, about half of that motion, maybe like a third to half of that motion, is coming from that AA joint all the way up at the top, that C1, C2. So how we do this test is we take our patient's head all the way up into flexion so that we're essentially taking out all of the segments below C2, because when they're at end range flexion, they can't really rotate. And then we rotate just the AA joint on top of, we really rotate that C1 on top of the C2. So we're rotating at that AA joint. And we're going to do it both directions because remember, cervicogenic headaches are usually unilateral. So they will only happen on one side. So as we're doing this test, we look for one side or the other that is either stiff or painful. And whenever I find that, I make a note and I write it down. And what we call that is we call that an asterisk sign. An asterisk sign means something that reproduces our patient's chief complaint that I can go treat later to hopefully reduce their chief complaint. So this is the cervical flexion rotation test, once again, designed to look at the AA joint specifically. And what we're looking for is unilateral stiffness or pain in that AA joint. The next thing here is our cervical UPAs, or this is a unilateral posterior to anterior motion. So here's a picture. We have our patient in prone. We're going to be right on that articular pillar, and we are just moving one segment right on the next segment. And once again, we are looking for hypomobility or stiffness and reproduction of pain. So we're going to do this from C1 to C3 on that unilateral side. So we'll do the right side, we'll do the left side. We'll usually do the side that doesn't have the headache first, and then we'll do the side that has the headache so we can compare one to the other. That's what I just said. We're going to compare side to side. And then once again, we're looking for reproduction of the patient's symptoms. So you're going to get to a segment and they're going to say, oh yeah, that's actually starting to like really refer up into my head where I get that normal headache. So we're going to look for that reproduction of symptoms or hypomobility. And then the final thing here is we're going to look for some OA type motion as well. So OA is that joint between the skull and the top of the neck. So it's our C0, meaning on the skull, to C1. Once again, we're comparing side to side, and once again, we're looking for reproduction of symptoms and or hypomobility. So that's all the things that we would find in our objective exam. So now, oh, sorry, one more thing. And this is what I told you guys a second ago. So this is our referral pattern for our cervical joints, right? So you guys can see everything from like C3 and above really radiates up into the head. But what you also see is that C3 also radiates into this region, right? And what do a lot of our patients say? They come in and they're like, oh my gosh, I have headaches. And if you could just squeeze this muscle right here, or like I've been getting massages, I have my spouse work this out, and it's just not taking my headache away. And it's really because what's happening is these joints in the cervical spine that are causing this headache are referring into those muscles. And then those muscles start getting angry because of this continuous referral from the joints. And then the muscles start to develop trigger points. And then they refer right back up into the head, right? So it is this cycle. And a lot of times that's what I'll hear from patients. It's like, I've been getting massages. I've been trying to, like use my Theragun here, and it's just not taking it away. That's a lot of times another like ding, ding, ding bucket or marble that I'm going to put in my bucket just because I see this so often. And once you can explain this to a patient, it's a major light bulb and you will have almost immediate buy-in because they're like, you're speaking my language. That's what I've been trying to tell people for years, right? But everything, you have to treat all of this together. So that brings me to what I was about to say. How do we treat these? So first and foremost, we have to figure out the stage and the irritability. We'll talk about this briefly because they're kind of complex topics. And then we're going to treat our relative impairments, which those are the things that we've already looked at. And then finally, the rest of it's just going to be evidence-based treatment. What does evidence-based physical therapy say that we need to do for people that have pain or people that have neck stiffness or people that have headaches? So we'll get into all of this. So the first part here is stage and irritability. So stage is really just, is this acute, subacute, or chronic or recurrent, right? If this is a headache that like just started, like someone just got off of their 12-hour shift and they are in the throes of this headache right now, that's an acute headache. And I'm going to treat that a little differently, right? My first and foremost goal is going to be to reduce those symptoms. And then I have to look at also irritability. Irritability is this concept of really what flares it up and how fast, and then what calms it down and how fast. So did you get your symptoms after 30 minutes of working on the computer, or did you get your symptoms after 6 hours of working at the computer, right? So a good rule of thumb is that things that are acute and or high irritability, we want to calm those things down. So our goal is going to be relieve symptoms more than chasing the mobility of symptoms. We want to just be calming down the pain. Versus if somebody has chronic headaches and they're low irritability, then we want to work on really building it up, building up the endurance, building up the strength, building up that postural tolerance, and really working on the segmental mobility of those specific areas. And then step 2, after we stage it and find our irritabilities, we want to treat those relative impairments. This is the slide that's going to seem like a pretty duh slide, right? If there's a hypomobile or painful OA, we're going to treat it. So we're going to mobilize it. We're going to treat the muscles around it, and then we're going to teach the patient how to treat it. If there's a hypomobile or painful AA joint, we're going to treat it. We're going to mobilize it. We're going to use some muscle energy techniques and some proprioception to help our patient figure out where that joint lives and how it's supposed to move correctly when it's not painful. And then we're going to teach them how to mobilize it. Is there a hypomobile or painful C2, C3? That should really say anywhere between C1 and C3. Then we're going to mobilize it, and we're going to treat those referral muscles, those muscles that refer down into kind of that upper trap. And then we're going to teach our patient how to mobilize it. So that, honestly, you guys, that's the easiest part. The hard part is finding those things in our objective exam. Once we find those asterisk signs, then we know exactly what we're supposed to treat. And we can be super, super, super bullseye accurate instead of just throwing spaghetti against the wall, which is what we never want to do as PTs. But remember, one size does not fit all, because how we treat these things is based on the previous slide. So gathering our acuity and our irritability is how. These are the whats that we treat, and then how, or to what extent, or to what vigor we treat them is based on the data from the previous slide. And then, like I said, the third step is, what does evidence say we should do for anybody that presents with neck stiffness and or pain? We should do some cardiovascular exercise. If cardiovascular exercise was a drug, it would be the most widely prescribed and successful drug the world has ever seen. Cardiovascular exercise affects every single one of our systems in a positive way. It even changes pain. It increases our pain pressure threshold, which means it lets our tissue tolerate a much higher level of stimulus before your brain starts to say, ow. That sounds like a great thing. If I'm in the business of treating people's pain and improving people's function, I definitely want to be doing some cardiovascular exercise with my patient. This also decreases inflammation and calms down our sympathetic nervous system, which is that fight or flight, which is especially important for people that have high stress jobs that are usually the environment in which they get their headache. And we'll talk about this in our case study in just a couple minutes. Then we want to be doing some upper quarter strengthening and endurance exercises, right? We want to do everything from our deep neck flexors. We want to get our actual global neck muscles. We want to do periscapular things. We want to be working cuff. We want to be working core, trunk stability. Pretty much everything from the waist up is all designed to help support the neck and help everything work together in a really good harmony so that we don't get stuck in these prolonged positions. It's not just about the posture, right? It's about everything working together. And then we want to make sure that we're dosing these things appropriately for endurance. If your patient has to sit at a computer for 8 hours, 3 sets of 6 probably isn't going to cut it, right? We need to be dosing things up around a higher fatigue threshold. We can do a thoracic manipulation, a high velocity, low amplitude thrust in the mid-back or the T-spine, because evidence tells us that anyone with pain from their belly button to the top of their head out to their fingertips is probably going to have a reduction in pain with a thoracic manip. So please don't forget about that in your patients with cervicogenic headaches. A cervical manipulation, we can also get up here, we can manip that OA joint. We can do a high velocity, low amplitude thrust based on what state you live in and what your license is. As long as we have appropriately cleared that patient. Good rule of thumb is that we don't typically manipulate the neck on the first visit. We want to make sure that the patient responds appropriately and that we've labeled their acuity and irritability appropriately. But then once we've done that, if they're safe and clear to have a cervical manip, have at it. And then finally, we need to educate and make sure our patients understand what they can do outside of the clinic. So what does this look like? IRL, in real life. I have middle schoolers. I don't think they know what IRL means anymore, but I'm inundated with all sorts of crazy Gen Alpha slang, but I'm going to go back to my millennial slang here. IRL, in real life, what does this look like? So here's our case study. This is the body chart. This is where we start in our subjective. So this is my patient that came in. This is where his symptoms are located. The back of the head, radiating up slightly, and then a little bit behind his eye. This is what we refer to as P1, or his primary problem area. All the check marks mean everything else is clear. So there's no numbness, no tingling, nothing down the arms, no dizziness, right? Because I've cleared everything else. So I already feel pretty decent about the fact that this is a cervicogenic headache. Our patient's a 36-year-old male police officer, high stress job, who presents in clinic with chief complaint of headache and neck stiffness. This has been off and on for about a year, right? So I have this neck stiffness and I have this chronicity. So it's already helping me stage that as well. We already know the location. His worst pain is a 6 out of 10 dull pain. Frequency is twice a week at the end of a 12-hour shift. So if we're getting headaches at the end of a 12-hour shift, that irritability is pretty low. And then the duration, it'll last for a few hours. Aggravating factors are looking at the computer on the nights that he has frequent traffic stops. So sitting in a car for a 12-hour shift, looking to the side on the computer as he's driving. This is a real patient. This is my husband. So denies the 5 Ds and 3 Ns. So we're ruling out all of these neurological signs and symptoms. He has no nausea or vomiting, no fevers, no photo or phonophobia, no change with exertion, coughing, or lying down. So how's our SNOOP? We're looking good. Nothing that should trigger a red flag is present. So I feel pretty decent that nothing scary is going on. And then, like I said earlier, the irritability is pretty low because it comes on at the end of a 12-hour shift. So now here's my objective exam, his cranial nerve exam, which I know we didn't cover, but because I'm a PT, I had to put it in there. His cranial nerve exam is clear. Once again, no neurological signs and symptoms that I need to be nervous about. His cervical active range of motion, left rotation, great. Right rotation, ooh, it's a little bit stiff. And he says, you know, that's about where I feel it. It kind of starts to radiate up into my head. His cervical flexion rotation test was positive on the right with some limited mobility. His OA was clear. I'm not worried about that joint. And with the cervical UPAs, his right C2, C3 was painful, positive for P1 or reproduction of that headache, and hypomobile. So I'm going to treat those things. We're trying to restore right rotation, and we're going to do it by treating my AA and my C2, C3 joints because those are the ones that popped up in my objective exam. He's also got some ropey suboccipitals on the right. We'll deal with that in the future. So we know we're clear for the SNOOP. We've already staged him. We already know what the irritability is. Here we have our relative impairments. So that's how we're going to treat him. And then we have our evidence-based treatment. So what are we going to do? Put it all together. I'm going to make him do cardiovascular exercise, running, right? Being a police officer is a very high stress job. You're in constant fight or flight. Our adrenaline is always running, which means that our sympathetic nervous system is always on high alert, which means our pain can be worse. So we want to make sure we're calming that down. Then I'm going to do some manual therapy. I'm going to mobilize that AA joint. And this here just means I'm going to mobilize it pretty vigorously because what I'm trying to do is chase the mobility because his irritability is low. So I'm going to mobilize it to a point where he's like, yeah, that's a little uncomfortable, but it feels effective. That's usually what I'm listening for my patients to say. I'm going to do the same thing for a C2, C3. I'm going to give him a nice little mid-back manipulation or high velocity, low amplitude thrust. And then we're going to follow that up with some exercise. I'm going to give them a self-snag, which is an exercise designed for our patients to mobilize their own AA joint so that he can start to restore that right rotation. We're going to do upper quarter endurance exercises. And then I'm going to educate him about, hey, you know, maybe when you're not on a traffic stop, get out and do some of these exercises. And I'm going to make sure he has stuff to do at home. And then success. I'm going to measure it. So I'm going to go back and remeasure all the things that I did day one as I'm treating them. I'm going to remeasure his relative impairments. And then I'm also going to be tracking in between our sessions if we're headed in the right direction. Hey, you used to get a headache after 12 hours. That was a 6 out of 10. Now you're only getting a headache 1 day a week. And the worst it gets is a 4 out of 10. That is good. So I need to make sure that I'm doing some specific testing to make sure, once again, I'm not just flying blind. And then if we need to, we can move that goalpost. So as we continue to improve, we can continue to chase the next thing. And then at the end of the day, always our goal is to promote patient independence. So making sure that he has things to do outside of the clinic, making sure that our patients understand what's going on, what we can do to help them, but then ultimately what they can do to help themselves after they get discharged from care, because that is what we care about the most. All right, with that, hopefully we didn't trigger any cervicogenic headaches. Zach, I'm going to turf it back to you. Thank you guys so much.
Elise, wonderful job, as always. I do not see any questions in the chat yet, but I'm going to give it a few moments just to make sure that you all have a couple moments to think of those questions. If you don't, feel free to message the link that was sent out to you all for this meeting. We will get back to you with those questions if those linger and you have to think off script and send those out. No worries. But I will give a couple moments here just to send those out. Elise, again, wonderful job. Takes me back to the fellowship days, years ago. And, your current role now, you just have a lot of folks that would benefit from this continuing education. Elise does some really great stuff at cervical spine. All right, going once, going twice. I could wait longer, but I know it's end of the year. People want to get home, finish up travel, finish up their work. All right, so that'll close it out for us here at the Excel in Your Future PT Career Series. We will come back next year, February, for our first session for 2026. Again, Elise, thank you very much for your time. We appreciate it. I know the students across this webinar will as well. And please, if you do have questions that you think of at a later date, don't hesitate to reach out via that message and send those questions to that email. All right, everyone, take care. Have a wonderful day.